How do we classify gastric carcinoma? So gastric carcinoma is basically classified based on the cell of origin. Gastric carcinomas are classified based on the cell of origin, from which cell they arise. Okay, now there are many types of cell in the stomach, and it is classified according to which cell it arises from. So based on this theory, the cell of origin, what would be the most common type of carcinoma in stomach? Based on the cell of origin, there are many types of cells that are present in the stomach, and based on this theory, what would be the most common malignancy in the stomach? Cell of origin. So according to cell of origin, what should be the most common malignancy? তার নামটা কি হবে? Yes, any idea? Any idea? Gastric foveolar cells থেকে arise করছে, most common type of carcinomas of the stomach. Now tell me. Most common would be malignancy. কালকে যারা ক্লাস করেছো কোলনের কার্সিনোমার, কি দেখেছো তোমরা? না না, ওটা কি মিউসিন, ওটা কি বলে? আমরা যে সেলটা দেখেছো সেটাকে কি বলে? What kind of malignancy is that? Adenocarcinoma. Adenocarcinoma. So stomach the most common cell type, the most common gastric carcinoma according to the cell type is adenocarcinoma, because there are other cells also in the stomach, but the most common is adenocarcinoma. So this is basically a rough classification which you must know, and this is what we are going to talk about. Adenocarcinoma. Adenocarcinoma. This is what we are going to talk about. And other than adenocarcinomas, we have other types of carcinomas also. For example, neuroendocrine tumors. Neuroendocrine, carcinoid, right? Then we get the mesenchymal tumors. For example, GIST, gastrointestinal stromal tumors. Then you get the maltomas. What is maltoma? Mucosa associated lymphoid tissue. That is mucosa associated lymphoid tissue oma. That is basically lymphoma. So many types of tumors can arise from the stomach based on the cell of origin, and out of all this, the most common is 90 to 95% of the malignancies in stomach are adenocarcinomas, and that's what we're going to deal today with. Okay, so adenocarcinoma of the stomach is by far the most, why I'm stressing so much is these are the basic questions which the examiner will ask you, and if you cannot answer adenocarcinoma, you say squamous cell carcinoma or lymphoma, that's not going to impress the examiner. So remember, 90 to 95% of carcinomas in the stomach are what? Are what? Adenocarcinomas, and that is what we're going to deal. So this is going to be our topic today. Okay, there are so many tumors, but at your level, at an undergraduate level, no point studying so much. Okay, we'll be concentrating on the one which is by far the most important, but that doesn't mean that you're not going to know the names of this and at least the cells of origin, because examiner still can ask you. He may or may not ask you in details. In details only adenocarcinoma will be asked at your level, but that doesn't mean that you're not going to study the other tumors. You need to know a little bit on them also, but in details about the adenocarcinoma. Okay? So adenocarcinoma constitutes around 90 to 95% of all gastric cancers. 90 to 95% of all gastric cancers are adenocarcinoma. So what are the precursor lesions? What are the precursor lesions? One is intestinal metaplasia, multifocal mucosal atrophy. Okay, so these two are the precursor lesions. This indicates that gastric carcinomas arise from a background, they can arise from a background of gastritis. Okay, it can be chronic gastritis, or it can be H. pylori induced gastritis, whatever. It can arise from a background of gastritis. So the precursor lesions include intestinal metaplasia and multifocal mucosal atrophy. So coming to the etiology. So these are all the etiological factors. One is H. pylori infection, which I just told you, H. pylori induced gastritis. Number 2 is diet. How is diet associated with gastric carcinoma? How is diet associated with gastric carcinoma? Gastric carcinomas, fortunately enough, gastric carcinoma cases are on the way down. They are falling. ওদের incidence আর বাড়ছে না, ওদের incidence টা কমছে. Okay. So how is diet? If you know this, the rate of the incidence of gastric carcinomas are falling, and that has something to do with diet. How are they correlated? What do you think? What do you think? Yes, fatty food is one thing. More than that, see, previously what happened was we used to eat a lot of canned food. Canned food. Canned food e ki ache jano? The preservatives are full of carcinogens. For example, nitrosamines, benzoapyrine, they are carcinogenic to the stomach. That is one thing. Second thing, now these canned foods are coming down because of improved refrigeration. Fridge amra khabar rakhchi. So we are not using preservatives. These preservatives are very harmful. Then we are consuming more, people are very aware now. People are consuming more of antioxidants, green leafy vegetables, vitamins. They basically act as antioxidants. So this is how diet is essential. This is how diet plays a role in gastric carcinoma. Previously, carcinogens, this benzoapyrine, nitrosamines, they are carcinogenic for the cells of the stomach, and they used to give rise to malignancy. But now the incidence of canned food has come down because of improved refrigeration. Number 1. Number 2, people are more conscious, consuming more antioxidants in the diet. For example, they're taking more of vitamins, more of green leafy vegetables, which act as natural barrier to gastric carcinoma formation. They prevent gastric carcinoma formation. So that is how diet is involved. Number 3, geography. Number 3, geography. Incidence is very high in countries like Japan, Chile, Costa Rica, etc., etc. Okay, and low in places like United States and all. So just know the geography, not that essential. Racial factors, I'm coming to it. Partial gastrectomy. Partial gastrectomy hote pare because of what? Reduced gastric acid secretion, resulting in more bacteria formation. Okay, hypochlorhydria. Reduced gastric acid secretion ke ki bole? Hypochlorhydria. So in that gastric stump, in the residual gastric stump, there is every possibility of gastric carcinoma formation. It can be a breeding ground for malignancy. Okay. Then pre-malignant changes in the gastric mucosa. These are all the etiological factors. One more thing you must remember, the incidence of gastric carcinoma, location ta ami bolchi. When I come to the location, I'm going to explain that to you. But at least as of now, know the etiology. Any questions on etiology? I guess it's pretty simple. Remember the diet very well. Okay, remember about the diet, and I'm coming to the genetic factors. Certain genes are involved in it. Okay. So location. So you know what are the parts of the stomach. You know what are the parts of the stomach. So over here, which part is most commonly involved? The pyloantral region. The region of the pylorus and antrum, they give rise to maximum malignancies. Okay. But incidentally, what we are observing now is there is an increased incidence of gastric carcinoma arising in the, which region is this? cardia. Why? 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 কেন? Gastric cardiate, which used to be historically low, in recent years, it has been seen that there is an increased trend of gastric carcinomas arising in the gastric cardia. তার কারণটা কি হতে পারে? Yes, reflux disorder. What reflux? Gastroesophageal reflux disorder giving rise to Barrett's esophagus. Barrett's esophagus, adenocarcinoma of the esophagus and adenocarcinoma of gastric cardia are morphologically similar and also in terms of behavior and therapeutic response. So if you consider Barrett's esophagus, and the most important cause of Barrett's esophagus is GERD. GERD. What is GERD? Gastroesophageal reflux disorder. So if you consider esophageal adenocarcinoma on one hand versus gastric carcinoma, adenocarcinoma of the cardia on the other hand, you see they're similar in morphology, behavior, and response to treatment. Remember this. Even though the most common site is this one, pylorus antrum, lesser curvature is more commonly involved in the greater curvature, all those things like everyone knows, but examiner can still ask you why there is an rise in gastric cardia. So that is the reason, because of GERD, gastroesophageal reflux disorder. Adenocarcinoma of the esophagus and gastric adenocarcinoma, they are morphologically similar and also in terms of behavior and treatment modality, response to therapy. Okay? So this is the cell of origin. Just remember the cell of origin. Or you can take this slide, you can take this if you feel like. It's available in the internet, everywhere it's available. No big deal. Just remember the name of the cells. Ours is adenocarcinoma is the one that we will be dealing with. Okay, so let's concentrate on adenocarcinoma. Okay, so how do we classify adenocarcinoma? How do we classify adenocarcinoma? One is according to the depth of invasion. One is according to the depth of invasion. Early gastric carcinoma and advanced gastric carcinoma. Early gastric carcinoma and advanced gastric carcinoma. And early gastric cancer So early gastric cancer ki hobe? What are the layers of the stomach? You get the mucosa, submucosa, muscularis propria and serosa. So early gastric carcinoma will be confined to the mucosa or at the most at the level of the submucosa. This is early gastric carcinoma. Early gastric carcinomas will be confined to the level of mucosa or at the most at the level of submucosa. Advanced gastric carcinoma will go beyond this. Is it clear? Early gastric carcinoma ki? Early gastric carcinoma will be confined. Early gastric carcinomas will be confined to the level of mucosa or at the most will go down up to submucosa. But advanced gastric carcinoma penetrates beyond submucosa into the muscularis propria or serosa. Depends, it can be transmural also. Clear? Hey, last bench. Is it clear? Can you explain? Can any one of you stand up and explain what I just said? What is early gastric carcinoma? What is advanced gastric carcinoma? You. Can you explain? কি করছো ওখানে? What are you doing? Stand up. You, last bench. What are you doing? Huh? Can you explain? Advanced gastric cancer spreads beyond the submucosa into the muscularis propria, or it can go down to the serosa. So, if all the layers are involved, what we call them? Huh? I know advanced carcinoma. Into advanced carcinoma, যখন সবকটা layer involved হয়ে যায়, what is the term we use? You should know these terms. Trust me. That is called a transmural infiltration. Transmural. Don't just say all the layers. ঠিক আছে, you're perfect. Transmural will give you 65, advanced gastric carcinoma, all layers involved will give you 60% marks. The moment you say transmural, it gives you 70% marks because examiner is more impressed. These are all the brownies that you need to know. You need to acquire to get those extra points. These are all the points you should know. If you want those brownies, the extra marks, you should use words, medical words, which actually make sense and impresses the examiner. Okay, that's how you should proceed. So this is called Borrmann classification. This is called Borrmann classification. Then it can be classified based on the pattern of growth, the growth patterns. It can be flat mucosal lesions. It can be exophytic carcinomas. It can be ulcerated carcinomas or diffuse infiltrating carcinoma or linitis plastica. Coming to that. And histological variants, based on histologic variants. That is called Lauren classification, based on histologic variants, which is also known as Lauren classification. So Lauren classification, we get the intestinal type of carcinoma. Intestinal type of carcinoma where the malignant cells are attached to each other and they infiltrate in cohesive fronts. Whereas you get the diffuse infiltrative carcinoma where the cells lose attachment from one another and they diffusely infiltrate the wall of the stomach. They diffusely infiltrate the wall of the stomach. So I just told you genetic factors, inherited cancer syndromes. Inherited cancer syndromes. The first and foremost thing that you must know is germline defects of E cadherin. Germline defects of E cadherin. What is E cadherin? What is E cadherin? Danish. E cadherin হচ্ছে basically ধরো এরকম সেল আছে না? So E cadherin, these are basically E cadherins. These are basically E cadherins. E cadherins are proteins which helps a cell to attach, cells attach to one another. And this is encoded by a gene called CDH1. E cadherin, what is E cadherin? E cadherin is a protein which helps in intercellular adhesion of cells. One cell binds to the other with the help of a protein called E cadherin. And this E cadherin is encoded by a gene which is known as CDH1. So germline mutation in CDH1 will cause the cells to dissociate with each other. And this is associated with which type of cancer? Diffuse infiltrative type. Diffuse infiltrative type of cancer. So germline defects of E cadherin because of a mutation in CDH1 will cause detachment of cells from one another, and these particular cells will infiltrate singly in a diffuse manner, not associated with each other like in intestinal type. So this germline defects in E cadherin is basically more commonly associated with diffuse type of gastric carcinoma, where the tumor cells will infiltrate as individual cells and they permeate the walls of the stomach. Number 2, mutation of beta catenin. Again, beta catenin encodes E cadherin. Beta catenin encodes E cadherin. FAP, familial adenomatous polyposis coli gene, FAP. This patients have multiple polyps in the colon, and they can give rise, so the defect lies in APC gene, adenomatous polyposis coli gene. So these patients predominantly develop carcinoma of the colon, and along with it they can also develop carcinoma of the stomach. HNPCC, again MLH1 MSH2 gene or TGF beta R2, whatever. HNPCC is hereditary non-polyposis colorectal cancer syndrome, HNPCC. Again, patients develop colonic carcinoma, most commonly colonic carcinoma, and along with it they can also develop gastric carcinoma. BRCA1 and BRCA2. BRCA1 BRCA2 কোথায় থাকে? ব্রেস্টে, সরি বলেই দিলাম, ব্রেস্টে থাকছে, তার ছাড়া থাকছে, আর কোথায় থাকছে? আর কোথায় থাকছে? ওভারিজে হয়। BRCA1 BRCA2, কোন অ্যাক্ট্রেস বলো তো BRCA1 BRCA2 মিউটেশন দেখে নিজে ট্রিটমেন্ট করেছিল? হ্যাঁ, so at least remember this name, at least remember this gene. Okay, and what kind of carcinoma in breast? Lobular carcinoma. So lobular carcinoma তেও না দেখবে individual cell penetrate করে, associated with BRCA1 BRCA2, most commonly associated with diffuse type of gastric carcinoma, diffuse type of gastric carcinoma. Then Lee-Fraumeni syndrome, Peutz-Jeghers syndrome, এগুলো কোলনের মধ্যে বেশি, যখন কোলন পড়ানো হবে তখন এগুলো বেশি জানতে পারবে, and to a certain extent first degree of relatives, family history তে থাকে. So at least know the first two, germline mutations in E cadherin, CDH1, ওটা definitely examiner will ask you, তারপরে beta catenin, and then give importance, prioritize the other genes also. যদি first দুটো জিন তুমি না বলতে পারো, examiner will not go to the others. Only if you can say the name of the first two genes, you have done more than enough to pass. Examiner will be happy. But if you can answer a few more genes, examiner will be super impressed. So now it depends what you want. But at least prothom duto boltei hobe. And if you fail to answer the first two genes, examiner will not at all be impressed with you. Ki korbe, that depends on the examiner. Okay. So at least know the first two genes. That's why I have put them in order: beta catenin and APC. Beta catenin and E cadherin and beta catenin. Start with E cadherin first. Start with E cadherin, then go to beta catenin. Okay. So this is what I have been telling you: EGC, early gastric cancer versus advanced gastric cancer. Early gastric cancer ki is this picture? Isn't it what I just explained? Isn't this what I just explained here? Can any one of you explain this? See, early gastric cancer, stage 0, early gastric cancer, stage 1 is also early gastric cancer. That is, stage 0 is up to mucosa, stage 1 is up to submucosa. So both of these belong to stage 0 and stage 1, both these belong to early gastric cancer. After that, it goes to advanced gastric cancer. Stage 2 is up to submucosa, up to muscularis propria. Stage 3 is, what is stage 3? Up to serosa, means the outer layer. That means transmural. Transmural. And then what is stage 4 tale? What is stage 4? Eitar পার্থক্যটা কি? Yes, see the picture, use your head, common sense, and tell me what it is, one person at a time. Whoever wants to answer, raise your hand and come up with the answer. No problem, make a mistake, big deal, come on man, make mistakes now. One of you raise hands and tell me what is it. এই জন্য পিকচারটা আমি তুলে দিচ্ছি তোমাদের সামনে, so that you see what exactly it is. সব সময় থিওরি মনে রাখতে পারবে না, but at least if you see the picture, it becomes easier for you, and then you can write according to your own language. It becomes far easier. So what is it? Stage 4 টা কি ইন্ডিকেট করছো? What is the difference between stage 3 and stage 4? Stage 3 ও transmural, stage 4 এও transmural আছে। তাহলে stage 3 আর 4 তাহলে দুটো আলাদা স্টেজ করলো কেন? Huh? What? What is complete and what is incomplete? Serosal layer take perforate kore it spreads to the adjacent organs. Got it? ঠিক metastasis না direct তো বলতেই পারো definitely. It's a direct spread actually. It's a direct spread. It has perforated the wall of the stomach and it has directly spread to the adjacent structures. আমি আসছি ওইটাতে, ওই স্লাইডে আসছি আমি, spread of tumors. Right? হ্যাঁ না? Is it clear? Is it clear? And there is something you should know as malignant gastric ulcer. পরে আসছি ওটাতে. Growth pattern. I just showed you one picture. Flat mucosal lesions. Remember একটু আগে বলেছিলাম? Flat mucosal lesions. Exophytic. Just remember, these two are exophytic. Exophytic means it will protrude into the lumen. কালকে যারা colonic adenocarcinoma specimenটা দেখেছো সবাই দেখোনি, I know that. Not everyone has seen it. Batch A has seen it. কারা কাল দেখেছো কালকে? You have seen না lumeনের মধ্যে কিরকম কোলনটাকে আমি দেখিয়েছি কালকে, ওটা I have taken that class. I have shown you and I have clearly said it's an ulcerated exophytic growth protruding into the lumen. So this is basically protrusion into the lumen. দেখো কিরকম ভাবে, isn't it? This is flat or depressed. This is flat or depressed. Then this is excavated. The ulcerated malignant gastric ulcer, a very important question, difference between benign and malignant gastric ulcer. So malignant gastric ulcers will have heaped up margins, rolled out edges, crater-like, crater, C-R-A-T-E-R. Where do you get crater? হ্যাঁ, মানে মন তো আসে তো ভাই অনেক উপরে চলে গেল, আর্থের মধ্যে ক্রেটার পাওয়া যায়, কোথায় পাওয়া যায়? কিসের সঙ্গে আমরা অ্যাসোসিয়েট করি ক্রেটারকে? হ্যাঁ, volcano. হ্যাঁ না, volcanoর সঙ্গে crater. So they have those crater-like edges, heaped up margins and all. That goes, very rarely you get malignant gastric ulcers, but you get. So at least at your level, you must know the difference between a benign gastric ulcer and a malignant gastric ulcer. Gastric ulcer class হয়ে গেছে. That gastric ulcer কিরকম দেখতে লাগে, the microscopic appearance of gastric ulcer is very important. The microscopic appearance of a gastric ulcer is very important, and you should know in and out what are the zones and draw the diagrams. Draw the diagrams very well. The base of the ulcer in a benign gastric ulcer is clean because of peptic digestion, whereas point gulo Prerona madam boleche ager class, I'm pretty sure. Whereas in malignant gastric ulcer, the base is necrotic. ঠিক আছে, এই পয়েন্টস গুলো কিন্তু জানবে. So difference between a benign ulcer and a malignant ulcer is very essential. আমি বলে দিচ্ছি কিন্তু এক্ষুনি. So write about the ages of the ulcer, study about the base of the ulcer. They are very important. ঠিক আছে, don't skip this question. এটা sure shot আসতে পারে. And when you draw, make sure you draw all the layers. Draw points গুলো তো দিলেই, along with it you have to draw a diagram, underline it, highlight all the important points and represent it in your copy. That's how it should go. Jodi bhalo marks pete chao, this is what you should do. Okay, and if you just write, you'll get average number because no one cares about your writing. People are more interested to see diagrams properly leveled. Okay, as an examiner, because that way it becomes easier for us to check the copy. And also, you fetch good number. So you do it for yourself, not for us. Okay? So these are the various growth patterns, a schematic representation. এখানে অনেকগুলো দেওয়া আছে, আমি পয়েন্টগুলো প্রত্যেকটাতে আসছি. ওকে, So coming to the morphology. First is intestinal variant, and then you get the diffuse variant. So first is intestinal variant. The difference between intestinal and diffuse variant is that intestinal variants infiltrate as cohesive fronts. With broad cohesive fronts means the cells this is a cohesive fronts. The cells are attached to each other. এখানে কিন্তু কোনো E-cadherin mutation নেই. There is no mutation of E-cadherin here. So detachment of the cells do not occur. They infiltrate as cohesive fronts, forming various structures. For example, glandular structures here. Look at this. This is purely glandular formation. This is papillary formation. So the tumor cells are attached to each other and they infiltrate the wall of the stomach as broad cohesive fronts without getting detached, forming various structures like papillary structures or glandular structures. Papillary structures or glandular structures. Morphologically, they present as exophytic masses which protrude into the lumen of the stomach, Morphologically, they form exophytic masses protruding into the lumen of the stomach, and microscopically, when you see this, when you take a section and see under the microscope, do histopathological process and see them under a microscope, you see this tumor cells, they infiltrate as broad cohesive fronts. Means the cells are quite well attached to each other. They are not detached, and they can be arranged in glandular configuration or papillary configuration. What are the features of malignancy? I am not explaining. You know it. Neoplasia is over. Hyperchromatic nuclei, prominent nucleoli, clumped chromatin, increased NC ratio, all those things are over. Okay. So these cells are obviously malignant. They're already infiltrating. Okay. Sometimes the cells can be lined by tall columnar mucin secreting cell epithelium. So this is basically mucin secreting. So this is what I have given: papillary, tubular means glandular, then this is mucinous, and sometimes poorly cohesive patterns. In poorly cohesive patterns, what happens is, this is the intestinal variant. In very poorly differentiated tumors, the tumor cells finally lose attachment to each other and they do not represent the parent organ of origin. So you can classify them based on grades as well differentiated. For example, this is very well differentiated. You can make out the glands properly. Then in between, this is one end of the spectrum. On the other end of the spectrum, you get this kind of cells where the cells have lost attachment to each other. That is poorly cohesive. Well cohesive, good cohesion, poor cohesion, and in between you have what is known as moderately differentiated. Where some of the glands, where you can get some gland formation, whereas others, individual cell penetration. Okay, but don't confuse it with diffuse gastric type. Okay, so this is the intestinal variant. In intestinal variant, there is a polypoidal exophytic mass which protrudes into the lumen of the stomach, and predominantly the well differentiated glands, they penetrate as cohesive fronts. They penetrate as cohesive fronts, forming glandular or papillary structures, and sometimes there can be mucin. Mucin lining the columnar epithelial cells, and sometimes, rarely, most commonly mucin is seen in colon. In stomach also at times you get enough mucin. There is enough mucin secretion which dissect the tissue planes. So that is called mucinous variant of adenocarcinoma, though it is more common in where? Colon. Colon will be taught to you. Okay, after your program, after your fest. So this is the endoscopic appearance. See, can you make out there's an exophytic growth protruding into the lumen? দেখো এখানে দেখি কি এই জায়গাটা দেখো. Look at this. This is maybe the normal stomach. The ruger will be gone in case of malignancy, and there is a clear-cut protrusion here. Look at the endoscopic picture, isn't it? Isn't there a mass which is protruding? Hanana, yes or no? Yes. Okay, thank you. Then coming to the diffuse variant. So diffuse variant ki bollam ami? Diffuse variant ki bolechi? What did I say? What did I say? E-cadherin, loss of E-cadherin because of CDH1 mutation or sometimes beta-catenin. So these cells, instead of broad cohesive fronts, they do not form any mass which projects into the lumen. They don't form any exophytic mass or polypoidal mass that project into the lumen. But they infiltrate as single cells and permeate the wall of the stomach. They penetrate as single cells, wall of the stomach. Clear? What happens is they invoke a heavy desmoplastic reaction. During this process, they invoke a heavy desmoplastic reaction, resulting in the wall of the stomach becoming extremely stiff and hard, or extremely stiff, resulting in the wall of the stomach becoming extremely stiff, giving rise to a leather bottle appearance. A leather bottle appearance, also known as linitis plastica. Remember that. They do not form any, they do not infiltrate as cohesive fronts. So technically, the cells have lost attachment to each other. মানে ইউনিটি ধরো নষ্ট হয়ে গেল, ঠিক আছে, ইন্ডিভিজুয়ালি সেলস গুলো পেনিট্রেট করছে. So there is no chance of forming a mass which protrudes into the lumen. So you don't get to see any mass. Rather, these tumor cells penetrate because they have lost attachment to each other, individual cell penetration into the wall of the stomach. And during this penetration, during this process, they invoke a heavy desmoplastic reaction. They invoke what? A heavy desmoplastic reaction. And because of this desmoplastic reaction, the wall of the stomach becomes extremely stiff, hard, giving rise to what is known as a leather bottle appearance. And this leather bottle appearance is known as what? This leather bottle appearance is known as linitis plastica. This is known as linitis plastica. Morphologically, what you get is, what are this type of cells? Yes, signet ring cells, I know that. So can you explain, can any one of you explain these cells? Because of extreme voluminous cytoplasm, mucin in the cells, এতখানি mucin থাকে না, this particular mucin pushes the nucleus to the periphery. It is extreme amount of mucin. See this pinkish thing, these are all mucin. And this mucin, they literally push the nucleus from the center to the periphery, displacing the nucleus. This voluminous mucin, a voluminous cytoplasm, they displace the nucleus from the center to the periphery. And this is known as, these particular cells are known as signet ring. These particular cells are known as, remember these names, linitis plastica, signet rings. Okay? Glandular differentiation is not a feature here. They don't form glands. Unlike intestinal variant where they form broad cohesive fronts, tubular or glandular or papillary configuration, here those things are not a feature. They penetrate as individual cells. They penetrate as individual cells, invoking a desmoplastic reaction, giving rise to extremely stiff wall, making the wall of the stomach extremely stiff, known as leather bottle appearance or linitis plastica. Microscopically, what you get is extremely voluminous cytoplasm and mucin, which displaces the nucleus from the center to the periphery, and these particular cells are known as signet rings. Signet ring cells. Signet ring cells are a feature of diffuse variant of gastric adenocarcinoma. Not only adenocarcinoma, you can get other elsewhere also, but when you come to stomach, it's a diffuse variant of gastric adenocarcinoma. Okay. So how does it spread? One is a local spread, stage 4 jeta bollam. Local spread kothay hote pare? In and around the stomach, duodenum hote pare. If it occurs in the piloantral region, it can spread to the duodenum, it can spread to the pancreas. Depends, huh? All the retroperitoneal organs, it can spread directly. Then comes lymphatic. And when you study lymphatic, there is something that you should know. What is Virchow's nodes? What are Virchow's nodes? Supraclavicular node. Supraclavicular node. So basically, sometimes it acts as a sentinel lymph node. So supraclavicular node, which side? Supraclavicular node, which gets involved in gastric carcinoma. Okay. So Virchow's nodes. There is something called sister Mary Joseph nodules. Sister Mary Joseph nodules. Periumbilical spread of gastric carcinoma. Sometimes the gastric carcinoma spreads in and around the umbilicus, forming nodules. And this is known as sister Mary Joseph nodule. Virchow's nodes, sister Mary Joseph nodules. Hematogenous spread kothay hote pare means via blood bone. Kothay hote pare? Lungs e jete pare, livers e jete pare, brains e jete pare, etc. etc. এগুলো তো ভাই কমন হয়ে গেল. Then comes one thing, transcelomic. Yes, Krukenberg's tumor. Transcelomic. Mostly the diffuse variant, they involve the ovaries. The bilateral ovaries are involved, and the origin is from the stomach. Most probably from the diffuse variant, not the intestinal variant, the diffuse variant. They spread into bilateral ovaries, transcelomic spread, giving rise to what is known as Krukenberg's tumor. So Krukenberg's tumor অন্য জায়গা থেকে কোলন থেকেও আসতে পারে, অ্যাপেন্ডিক্স থেকেও আসতে পারে, ব্রেস্ট থেকেও আসতে পারে, বাট যখন স্টমাক থেকেও স্প্রেড করতে পারে, because we are studying stomach, so we'll be talking about that. So this is known as Krukenberg's tumor and spread is transcelomic. এগুলো মাথায় রাখতেই হবে. Okay. Is it? I have mentioned Krukenberg's tumor. কাজ করছে না এটা, ব্যাটারি খারাপ আছে. So intestinal and diffuse variant, okay, not so essential, I've just put up. So what would be the clinical features? One question asked me via clinical features. So there is early symptoms and late symptoms. So early symptoms initially they are non-specific. Non-specific, মানে যে gastric carcinoma তেই হবে, not necessary. It can happen in other conditions also. So like tired or fatigueness, nausea, heartburn, loss of appetite, abdominal fullness, indigestion, এগুলো অনেক কিছুতেই হতে পারে. So these are the early stages. If we ignore them, then it may become problematic. So what would be the late symptoms? Late symptoms, একটা হতে পারে jaundice হতে পারে, yellowish discoloration, বাকিগুলো মোটামুটি common, loss of weight, dysphagia, bloated feeling because of an abdominal mass in intestinal variant, nausea, vomiting, etc. etc. These are all the late variants, late symptoms of gastric carcinoma. So there's something called early symptoms. Okay, remember the clinical features, that is more than enough. Dyspepsia, dysphagia, etc. etc. Then later case ki aste pare loss of weight and all, which is also common to most malignant tumors. Okay, so these are all the symptoms. Coming to investigations are very important. Investigations are very important. Okay, serum tumor markers. Serum tumor markers. Serum tumor markers er konta? CA 72.4, CEA, carcinoembryonic antigen. CA 72.4, CEA. Exfoliative cytology, gastric lavage. What we do is we inject some fluid and take the cells out. Lavaging korchi amra pet theke. And we see them under microscope. We see that lavage under microscope and look for any malignant cells. So gastric lavage, that is basically exfoliative cytology. Exfoliation means ki? Exfoliation kotha mane ki? Huh? Ki? Spread, no, not spread. Exfoliation mane ki? Jhore poda. Exfoliation mane jhore porche. ঠিক আছে? Then endoscopy. Endoscopy helps us to know the extent of the lesion and also take representative biopsies. Now endoscopic lesions are very helpful, especially flat mucosal lesions e kintu endoscopic lesions খুব ভালোভাবে হেল্প করে। যদি একটা ulcerated mass হয়ে যায়, exophytic mass হয়ে যায়, then endoscopy ছাড়াও মানে endoscopy প্রয়োজন পড়ে না, MRI আমরা করে দিতে পারি, কিন্তু endoscopy is very essential in countries like Japan, Chile, where it is very endemic, where gastric carcinoma is very endemic. Are endoscopy ভীষণ helpful in flat mucosal lesions যেগুলো সহজে আমরা MRI, CT তে অন্য কোনো USG তে আমরা identify করতে পারি না. Over there endoscopic lesions are very essential, and not only endoscopic lesions helps to identify the flat lesions, but endoscopic lesions also helps endoscopic biopsies endoscopy helps us to take biopsies from representative areas. So flat mucosal lesions are very helpful, and endoscopic lesions হচ্ছে সেই সব জায়গাতেই helpful where the malignancy is endemic. In countries where it is not endemic না, যেখানে malignancy খুব একটা হয় না, over there endoscopic lesions are not of help, but endoscopic lesions are of help in areas where this is endemic, and for flat mucosal lesions from where not only we can know the extent of the lesion, but it also helps us to take representative lesions from the involved areas, representative biopsies from the involved areas. Okay? Then imaging techniques, CT scan, MRI, USG, they are mostly for advanced cases. They are to rule out any secondary deposits. They are used to rule out any secondary deposits, CT, MRI, USG. So these are all radiological techniques. Then Borrmann study. Borrmann study হচ্ছে it identifies an irregular filling defect, just know the name, irregular filling defect in linitis plastica. আর তারপরে আসছে IHC, FISH and histopathological examination এর পরে আমরা actually we do IHC. But if you remember these points, that is very important. Coming to prognosis. So prognosis কিসের উপর depend করছে? Depth of invasion, one, extent of nodal and distant metastasis. ঠিক আছে? Extent of invasion. Early gastric carcinomas have far better prognosis than advanced gastric carcinomas. The 5-year survival rate for early gastric carcinoma is around 90%, whereas it drastically comes down to around 30-35% for advanced gastric carcinomas. And obviously extent of nodal and distant metastasis, যদি lymph node spread করে যায় বা distantly spread করে যায়, there is metastasis, obviously it has a poorer prognosis. So going with that theory, early gastric carcinomas, they have a better prognosis, as I just mentioned, and advanced gastric carcinoma, as the name suggests, their prognosis is not good at all. So with this I finish gastric carcinoma. Your next topic is tomorrow, inflammatory bowel diseases.